All right. I'll stop talking. Co-chairs, have at it, please.
All right. Welcome everyone to our September first time we're having a meeting that's split into two-hour increments. So welcome everyone to our meeting. We're going to have a couple of things. We'll do the roll call in just a second, but one of the things that we'll be highlighting today is the local system of care spotlight. Haley Van Horn with Lane County. We're going to hear and discuss recommendations from the Professional Authorization Subcommittee, HB 4151 Work Group, vote scheduled for our 9/16 meeting. We're going to have committee reports. We're going to review the draft SOC legislative report that's due by the 15th. And then at the end of our meeting, we'll have announcement time frame. That is our overview for the agenda today. So I'll turn it over to Adam.
Yeah. All right. Let's do roll call. Allison Stark and Sonia Little Deer Evans. I know I saw Allison. Yep, I see you waving. I got you.
Sonia had something she had to do today. She's excused.
Okay. Jackie Serrano and Sandra Santos.
Presente.
Hey. Jackie out today, maybe? Don't see her anyway.
I don't see her.
Robin Henderson and Anderson Dubois. See Robin. Hi, Robin. I got you.
I'm here.
And I didn't see Anderson. Okay. Kyle Johnson and Adam Peterson.
Kyle, I'm here.
Adam, I'm here, but I'm gonna have to sign off now, but I'll be back for the second hour. Apologize, folks, for having to leave a little bit in the middle.
Copy. That's all good. Appreciate the heads up. Judge Marisa Gates and Jesus Nunez Pineda.
Present.
Jesus here.
Kati Mosley and Emily Cooper.
This is Kati. I am present.
I'm here as well.
Dan Toma and Cindy Cecil. Hey, Emily. Sorry.
I'm here.
Cindy's excused.
Okay. Ebony Clark and Carissa Cousins. Okay. Zafir Michael Berry, Jill Archer.
Zafir's excused.
Okay. Lacey Andreessen, Annette Magicotami.
Here.
Okay. Dana Hiddle and Andrew Grover. And is Dana here, or I forget the gentleman who's taken over for Dana?
She will be replaced by a gentleman. I believe his name is Eric. He is not available. He's traveling today, so he's not available, but he'll be here next month.
Okay. Andrew Grover.
Andrew's here.
Alicia Overstreet.
Alicia's here.
And I am here as well. Perfect. Let's go over our shared agreements, right? Family and youth are welcome to participate in the meeting at any time. If you're a member of the public, but you're not youth or family, you can speak during the public comment period and contribute in the chat. You can also send private chats to Joylene Carter, Alicia Overstreet, or Annette Magicotami if you have a comment you want someone to say for you. Group agreements. Be present and participate. Be respectful, try not to interrupt, and then, of course, use the names and pronouns people introduce themselves with. Try and avoid acronyms, and we'll look to the chat to help us out for definitions or ask for clarification if we do make a mistake and use an acronym. We welcome varied and opposing ideas. Our ideas can be challenged, but do not challenge the person behind said idea. Honor those with quieter voices and lean in or lean back. We won't be problem solving for individual crises or situations, but we're happy to take that offline and support you afterward. Our purpose, of course, is improving the system of care here in Oregon. So let's keep a focus on that. And while we're doing that, be mindful of the power dynamics that exist in this virtual space. And above all, Let's not continue to just examine the problem, but let's propose solutions, folks. Like, that's why we're here, to make this better, and we can't do that unless we're talking about solutions. So let's try and live out those group agreements to the best of our ability. While we're making decisions, we also use the GARE tool, Government Accountability Tool for Racial Equity. GARE. Almost made my first acronym mistake, folks, and we're not even 15 minutes in.
Government Alliance.
What's that?
Alliance. The A is for Alliance.
Yeah. Okay. Sorry. It just disappeared in the chat. Whoever's presenting. Thank you. It requires us to ask the following questions every time we make a decision on policy, program, or budget. It's also on our consensus slide in our discussions, and those questions are: what are the racial equity impacts of this decision? Who will benefit from or be burdened by this decision? Are there strategies to mitigate any unintended consequences? And is completion of the full racial equity worksheet warranted? Thank you, Sonia, for dropping that in the chat. All right, back to Annette. I think we have one topic before the report on HB 4151.
All right, I'm going to introduce Haley Van Horn. She's our spotlight this afternoon. Is Haley here?
Hi, Annette. Sure am.
Hey, Haley. Nice to see you.
Nice to see y'all.
We're excited to have you today. She's from Lane County System of Care. She's going to spotlight some of the work that's happening down south, and we welcome you. Go ahead, take it away, Haley.
Oh, thank you, Annette. Hello, friends. I've been attending this meeting for a minute and I've never spoken up. So I feel like as excited as the first time I went to Six Flags as a kid, right? Like same thing. So thank you for having me today. Thank you for this opportunity for us to speak a little bit about our individual regional systems of care. I have just the briefest of PowerPoints to keep myself organized and on task. So give me just a minute as I accomplish my biggest hurdle, which is going to be sharing my screen, which no matter how often I do it, which is a lot as a somewhat professional meeting facilitator, it makes me anxious every time. So 1 second. All right, friends, I'm not going to keep you here in this awkward note version. Let me get us where we're going. All right, is everybody with me?
We're with you, but we are on the last slide and we are seeing your weird like share to teams thing.
Just a second. Let's see. As excited as I am about my meme, right? How's that?
That is still your share to teams thing, but it is the
Okay,
first
great.
slide.
Well, we've got half of it right. Let's do a switcheroo. Here we go. That's a professional term, switcheroo.
There you go. We're with you now.
All right. First task accomplished. Welcome. Thank you so much for having me again to talk a little bit about the Lane County System of Care. My name is Haley. I use she, her pronouns, and I am excited to be here with you all today. So first and foremost, I want to talk a little bit about the SOC team that we have here in Lane County. So I am the System of Care coordinator, but I also want to mention my teammates, Lindsay Hodges, who is our admin support and definitely my peer and partner in so much of this work, as well as Brittany DeLiso, supervisor for the program, and also such a partner in this work. I want to make sure to give a huge shout out to our co-chairs. We are so fortunate to have all of them. Some of them have been around for a very long time, and we will take that when it comes to people who are very passionate about what we do here in Lane County with our system of care structure. And then last but certainly not least, I want to give a shout out to our CCO partners, Trillium and Pacific Source. And just, we are so thankful that they trust us with this work that we do in partnership with them. So I have about 8 more minutes of your time, maybe 7, given how long it took for me to figure out that whole sharing screen thing. I want to share a little bit about what makes our Lane County system of care successful and then some of the areas that we struggle in, right? So I think just to get us started, one of the things that makes us really unique as a system of care is that we are Lane County government employees first and foremost, right? So unlike so many of my amazing peers in the SOC world, we are on the ground in Lane County where we live and work, and we're not based out of a CCO. As I mentioned, we are partnered with our CCO friends to do this work, and we have been since around 2014. So with this team model that we utilize, it allows for us to, instead of just having one SOC coordinator, we are able to kind of divide and conquer the multitude of tasks that are associated with the regional system of care. And then it also allows for coverage when somebody needs to, be human and be out for some time. So another thing that I think I'm very proud of for our system of care, and it doesn't just originate from my time in this role, which is about 3 years, although I've been with Lane County government, specifically under the behavioral health department, since 2017, but we have a long-standing presence of youth and family voice involvement with a heavier load of youth voice participants. And so I definitely want to call them out and speak to our We Are the Voices of Youth members who have been participating for many years now. They came up with that name, and we're kind of in a little bit of a limbo, which I can speak to in a minute, but nothing that we can't overcome together. We also have some excellent family voice folks who have joined us and are excellent advocates at both the local and state levels. I want to give a shout out to our committed community partners. We have been so fortunate to have people and representatives consistently around the table, for the past 11 years. Some of them serving as co-chairs, some of them as previous co-chairs, but even through the thick and thin with a bit of a turnover and figuring out, the right role and the right person for this job, just a little toot my own horn, they've stuck with us. Speaking of our amazing co-chairs, we are very proud to have 2 family voice representatives serving as co-chairs, as well as one amazing youth voice who is no stranger to most of you at this meeting. It's Abigail Torres, who I'm also proud to say serves on the Youth Action Council for the SOCAC. One of the things that I think this group will be most interested in is what do we do with our grant funds at the SOCAC? We are so appreciative that you're able to support us with. So a percentage of that goes to support the SOC team model, where we're able to have a more collaborative governance structure and just being able to kind of support the SOC efforts on a wider breadth. But then another large part goes to supporting a local respite project with our amazing partners at the ARC of Lane County. So since 2023, we have been offering a 1 to 2 time a month event in Lane County for any children or youth ages 5 to 12 with complex needs and their siblings within that age range. The 2 events, one has been in Oak Ridge, and one has been in Springfield, where the amazing ARC office is located. And since 2023, we've served about 200 children and youth through that respite program. And that breaks down to about 137 families that have been served. And so we're continuing with that work for another 2 years with the next round of grant funds. And we're going to open up the eligibility a little bit, because we know that it's not just the 5 to 12 age range and their families who could benefit from that break. Another couple of things, I'm not going to read off every one here just to save our time, but I do want to speak about how we have taken the system of care and really tried to make it more approachable, even fun for especially our family and youth and our community partners too, to be honest, to attend. And one of the things that we did to promote clarity and really speak to the scope of what everyone is responsible for is we went from 3 separate charters to 1 charter. We don't currently operate off of a strategic plan, although we hope to change that. But this 1 charter document that we really worked to get it towards readability that was welcoming to all, it really serves as kind of like a touchstone for the work, and that we're able to glance back on when we're kind of figuring is this out of scope or is this something that we do? And as you can see here, there are other things I would love to brag on if we had some more time, but I will move over to just a few of the struggles, but definitely end with some positives. So like so many of our system of care partners in other regions, one of the things that can make system of care work difficult is the limited FTE that can be associated, right? Like we're well aware that there are so many things that CCOs are responsible for and so many very crisis-oriented things that maybe take precedent with the limited amount of funds that everyone gets. So it ultimately results in kind of some limited bandwidth for the system of care team here in Lane County. We're happy with our team model, and it could benefit greatly from having, additional magical funds that could help support and grow us. I spoke to us being a little in limbo with our youth voice. While we have some amazing youth folks, and we used to have the capability to have kind of a separate space for our amazing youth to come together, with a change in kind of my bandwidth as a 0.5 SOC coordinator, as well as one mom to two tiny humans. It just kind of changed my ability to be present for them after hours. So we're working together with our amazing youth to kind of figure out how can we keep holding space, how can we keep intentionally creating space for our youth, without just letting all of the amazing work they've done fall by the wayside. So Lane County is a rather large county as well. And although we have a ton of participation, the majority of that is from Eugene and Springfield and a few rural areas. I myself reside in Cottage Grove. Come and see us. We have lots of covered bridges, but we really would like to see participation from our coastal region and other areas that it's been kind of difficult for people to join, even with a virtual platform. So one other thing that I'll call out is just that we tend to get fewer barriers than other regions. And we don't necessarily see that as a negative because it allows us to dig in a little deeper to some barriers. But a goal for this next year is to follow suit from some of our amazing peers in other regions and be very strategic about where we hope to get barriers from, with an emphasis on our family and youth voices, letting them know that we're a place where they can send something and be a part of creating that change. So I'd say one other positive I want to make sure that we end on is just kind of that connection that us as Lane County employees, folks living in Lane County, have, is a connection to all the different initiatives that are happening here. Because we are Lane County employees kind of facilitating this work, it means we also have direct connections to our amazing partners in other departments, as well as our behavioral health clinic actually being one of the providers in the area. I saw that Dr. Ratu is in here, and he is an amazing advocate and leader for our behavioral health clinic, and one that I think we all look to for, the advice and things that are needed in times of kind of like the uncertainty that we're in right now. So very grateful to have him in this space and doing the work that he's doing. So here's that wonderful slide, right? What I want from you all, I'm sure it's no surprise, we don't have any representation at the SOCAC, right? And so we do look to change that. But in the meantime, it would be so helpful if you know any friends in Lane County that you want to recommend join us. If you have any ideas for us based on what you've seen be successful in your region, if you're attached to a local system of care, we'd love to hear from you. And then just last but not least, thank you so much for this time. Thank you for what you all do. And I really enjoyed the random check-in questions about potatoes and the like. Thanks.
Thank you, Haley. I really appreciate your presentation today. I always learn so much about what's happening down in Lane County. So thank you so much. I look forward to seeing you again in these meetings. Appreciate it. I'll go ahead and turn it over to Adam.
Yeah, thanks, Haley, and thanks, Annette. So next up, we do have a decent chunk, about 45 minutes of time, to discuss the outcomes of the Professional Authorizations Work Group, House Bill 4151, which folks should be familiar with. This came to the System of Care Advisory Council in the last legislative session, not the one that just finished, but prior, I believe, the short session. And so Kate McLaughlin from the University of Oregon, Balmer Institute, and members of the 4151 group are here to share their recommendation for a new credential for behavioral health workers here in Oregon. So today we're going to hear and discuss their recommendation. And then on the September 16th meeting, we will vote whether to adopt this recommendation. So if adopted, it will be sent to the legislature, and then that will allow the legislature time to craft legislation for the 2026 session if they choose. It will also be included in the final 4151 report in December that comes out, that will explain more of the context and recommendations of that work group. So I think I've talked enough, and now I'm going to turn it over to Kate McLaughlin. And I see you there, Kate. Hey, how are you?
Hi, thanks so much for having me, everyone. And I will apologize in advance. I am getting over COVID, so if I start to lose my voice, you will understand why. I'm going to share my screen to get us started. And I wanted to share, I think on the slides it said it was myself, Jamie Vandergaan, and Eric Martin from MacBo who would be joining. Eric was unable to make it today, so Jamie and I are going to be leading us through this discussion that focuses on the first set of legislative recommendations. We're really just focusing on the first here today to come out of the House Bill 4151 SOCAC subcommittee. So,
and just so you know, sorry to interrupt you. I believe Eric was able to adjust his schedule. And
is Eric here?
I'm here.
Yay! Hi, Eric. I'm glad you're here. So all three of us are here. That's great. Can you all see the right version of my slides before I get started?
Yep, looks good.
Okay, wonderful. So here's a roadmap of what we are going to be reviewing today. The first is just a little reminder about what House Bill 4151 was all about and the current legislative recommendation that we'll be talking about today. Second, I'm going to talk about the rationale for that recommendation and what we think some of the positive impacts would be on systems of care in the state. And I think that during these presentations, the norm is for SOCAC members to kind of interrupt and talk about questions along the way. If folks don't mind letting me get through kind of the first couple of sections, just so we've got, the full recommendation and why it was made out there, that should take me less than 10 minutes. And then for the rest of the time, I'd, welcome questions along the way or at the end, whatever folks prefer. And the sections after that, so I have spent a lot of time talking with all of you over the past couple of months about this recommendation in advance of this meeting. You all have raised amazing questions, some concerns. And so what I've put together is a section that reviews both the concerns that came up in the conversations as part of the subcommittee 4151, as well as with all of you, and sort of, how we've proposed to mitigate or address concerns about this recommendation that have been voiced. I'll end with just a summary of what the recommendation is, and then leave whatever time we've got left for questions and feedback from all of you. Okay, so let's start with House Bill 4151 and what we're recommending. So first, just as a reminder of what this bill was all about, and side note, Adam, I have to see my full slides, have to minimize all of your faces. So if questions come up, if there's a hand raise I miss, if you don't mind just interrupting me, that would be amazing. So the goal of 4151, and this is right from the bill, this language that you see, was to identify state-issued professional authorization options or credentialing options for existing and emerging behavioral health professions, and to determine the structures and supports needed to sustain the youth behavioral health workforce. And there was a focus specifically on professions that are trained at the bachelor's level, as well as those that have the potential to increase both equitable access to behavioral health supports, as well as the diversity of the workforce to be more reflective of the youth population of our state. So with those goals in mind, I'm going to review a legislative recommendation that came out of this 4151 subcommittee. What you're going to see on this next slide is the exact words from what the subcommittee actually voted on. I'm going to dig into the details a little bit more as we move forward, but you're just going to see kind of a high-level summary to get started. So specifically, the recommendation is for a new credential for a licensed bachelor's level youth and family behavioral health provider that should sit within the Mental Health Regulatory Agency, which is the agency that currently oversees the Board of Psychology, as well as the Board for Licensed Professional Counselors. So for this new license type that's being proposed, the eligibility would be folks who have graduated from an applied bachelor's training program. So in other words, a training program at the bachelor's level where you actually get the opportunity to deliver clinical services under the supervision of a licensed professional as part of that program. There's a number of existing programs in the state that are structured in that way. We've listed just a few examples here: bachelor's in social work programs, the child behavioral health program at the University of Oregon, and a few family human services programs in different parts of the state, as just a few examples. The scope of practice here really emphasizes, I'm going to emphasize this repeatedly throughout, early identification and prevention of behavioral health concerns. But the full scope of services that folks with this license could deliver is summarized here. So early identification services, psychoeducation, skills training and support, brief intervention, prevention services, as well as care coordination and case management. Really critically, this would be a role that requires, in all cases, formal supervision by a licensed provider at the master's level or above to deliver services in any setting. And there's a range of settings that we would imagine folks with this license would deliver services in, including pediatric primary care, schools, which as a side note would also require licensure by TSPC, which I'm not going to dive into today, community-based organizations that deliver youth mentoring services, mental health agencies, and any other settings of practice that would ultimately be approved by OHA. But the ones listed here are sort of primary settings where we would imagine folks with this license type would deliver services. The hope would be that services would be covered by the Oregon Health Plan and private insurance, but as I'll note in a later slide, that still remains to be sorted out if this in fact passes. And then just to address that sort of last part of the goal of HB 4151 around workforce diversity, the hope is that creating a license of this type is not only going to expand access to services for kids, but by reducing barriers to entering the field, the hope is that this plays a part in increasing workforce diversity. And I'll show you some data later on that Eric has shared from MACBO, showing, for example, differences in workforce diversity for QMHAs versus licensed providers currently in Oregon. And then finally, in terms of culturally responsive services, as part of creating this license type, there would be required competencies that would have to be addressed, both in terms of the coursework that folks completed to be qualified for this license type, as well as in the qualifying exam in culturally responsive and inclusive practices. And I'm going to dive into that in more detail as we move forward as well. But this is the official recommendation. This was also a piece that the subcommittee voted on. And I just want to really emphasize the things that are not included within the scope and settings of practice for this new license type. So the first is that these folks would not be engaged in any kind of diagnostic assessments and cognitive or educational assessments, managing medications or prescriptions in any way, psychotherapy or longer term intervention services. And I have this emphasized in bold, independent practice. And I'm just going to keep repeating that over and over, that this would be a supervised role in all cases. When we think about settings of practice, the same applies. So this is not someone who could ever, for example, open a private practice or practice independently in a setting where they were the only behavioral health provider. This is really a team-based role that someone who would work within a team that includes a licensed provider at the master's level or above. And just for an analogy, this is really similar to a CNA or a certified nursing assistant in Oregon and elsewhere around the country. These are nurses that have to be supervised by either an RN, a registered nurse, or a licensed practical nurse to be able to deliver services. So it's kind of a yoked role in the same way that we are proposing for this new license type. Okay, so some more details about this proposed credential. So first, here's the name that we're floating, although we're super open to feedback and this has not been finalized. Some folks might remember we started with behavioral health specialist as the title. We sought a lot of feedback, including from many of you from the SOCAC Family and Youth Councils and from other organizations around the state, and we have updated it to a licensed behavioral health and wellness practitioner. That name is actually identical to a credential that was just enacted in legislation in Nevada that I'm going to mention again a little bit later in this presentation. And it integrates feedback from the SOCAC Youth Council, specifically a preference for the term wellness to be included in addition to behavioral health, as well as that a term like qualified or licensed be used to really specify that these folks have met a standard of training to be able to use this title. And then it also integrates feedback from SOCAC Family Council, as well as other behavioral health organizations in the state. They really didn't like the term specialist for a whole range of reasons. So we've updated that to practitioner, which was preferred. So the scope of practice, as I mentioned, really emphasizes a couple of key areas that I'm going to bold here that are really distinct from existing behavioral health roles in the state currently, or other credential types, with an emphasis on early identification and prevention of mental health problems. And then, of course, the kinds of things that all behavioral health professionals do around care coordination, collaborating, and consulting with other professionals and peers are also part of that scope of practice. And again, here are the things that are outside that scope. I'm not going to repeat them for you again, but just as a reminder. Here are the core competencies that we've identified as being associated with this new license type. The ability to use evidence-based approaches to identify behavioral health concerns early, like, for example, using screening tools. Being able to deliver psychoeducation about mental health and behavioral health, as well as about interventions, delivering skills training and support, as well as what we conceptualize as brief kind of early interventions that are evidence-based and designed to promote wellness, as well as to prevent the onset or worsening of behavioral health concerns. They'd also engage in, standard practices around risk identification, referral, and care coordination, culturally responsive and inclusive practices, as well as collaboration and consultation with other behavioral health professionals and with peers. Okay, so how would competency be evaluated? It would be evaluated using pretty standard things for a behavioral health profession. The area that I bolded is sort of what distinguishes, one of the things that distinguishes this new license type from existing sort of entry-level credentials that we already have in Oregon, like the QMHA. So in addition to required educational training, these folks would have to get supervised clinical experience that is part of their bachelor's degree. And that is something that is not a part of the existing qualifications or requirements for QMHA, for example. They'd have to pass a qualifying exam, they'd have to do continuing ed, and they'd have to have attestation from their supervisors about the quality of their care. I want to address the educational alignment with this scope of practice. So the idea here is that the educational requirements for this license would specifically prepare these folks for a scope of practice that's really emphasizing early identification and prevention. It would require coursework in those areas, as well as that supervised applied practice in delivering early intervention and prevention services as part of their educational degree at the bachelor's level. And again, just emphasizing that the scope really is distinct. Part of the 4151 work was to do kind of a landscape analysis of all the credentials in Oregon. Y'all probably know there's a lot. That was quite a map, and OHA has got a great map of this on their website. But despite that, this sort of scope with an emphasis on early identification and prevention is distinct from credentials that already exist in the state. I also want to address that, QMHAs, which are currently sort of the primary kind of entry-level behavioral health credential in the state, folks with that credential can deliver direct care, can deliver skills training and support, engage in case management, also under supervision of a licensed provider. And this also requires a bachelor's or equivalence. However, this sort of requirement for supervised applied clinical practice as part of the bachelor's degree is unique to this new license type that we're proposing. And it's aligned with kind of a slightly extended scope beyond what QMHAs do that is really emphasizing early identification and prevention. Okay, so I'm going to talk really briefly about the rationale, and then we'll sort of welcome folks interrupting me for questions along the way. So why a new credential? Why is this sort of the recommendation we're making? So first, we've identified, as I've mentioned, that the scope of practice for this new role is really distinct from existing professions and credentials, with its emphasis on prevention services and early identification. But also, and I'm going to come back to this, the focus on service settings where prevention services services can easily be integrated, but that often lack behavioral health workforce. So settings like schools, pediatric primary care, and community-based organizations that work with kids and families to do things like mentoring, but often lack a behavioral health service provider. So a credential is also essential to do what 4151 was focused on, which is thinking about how do we expand and sustain a more diverse behavioral health workforce in entry-level professions. So credential helps to professionalize these entry-level roles. It's required as a first step as we think about how to reimburse for services. But really critically, it allows for practice to be regulated. And that's relevant to sort of this last piece. A credential is really essential for consumer protection, right? So it allows the scope of practice to be regulated in a really clear way. It creates clear standards around the training experiences you've got to have and the kinds of services you can deliver. And it provides really important guardrails around that practice by creating structures that ensure ethical practice within the boundaries of your scope, as well as creating structures to kind of prevent practice for individuals who don't meet those standards or who have engaged in practices that are not aligned with that credential. So it's really about consumer protection as well. And then finally, this is aligned with work, an increasing amount of work in other states where these similar types of bachelor's level credentials have been created. Oregon would actually be the 7th state to create this type of credential. The most relevant, actually just a few months ago, Nevada passed a bill in their 2025 legislative session for a licensed professional at the bachelor's level using the same name we're proposing here. That license type is actually also identical to what 4151 is proposing in terms of the scope of work and required educational training. Okay. Why not change the QMHA? This is a question that's come up a lot. And since Eric's here, I'm not going to put him on the spot and ask him to go through the slide, but I welcome Eric actually to hop in because this was a conversation we had pretty actively as part of 4151 is where's the right home for this? We ultimately landed on MHRA, but thinking about MACBO or changing the QMHA credential is also part of our conversation. And ultimately, one of the main drivers of this decision was that the QMHA credential has setting restrictions and funding restrictions that were poorly aligned with a new workforce that's really focused on early identification and prevention. So if you remember, the settings where we expect these folks to practice are places like schools, primary care, community-based organizations. Those are settings where folks who have a QMHA cannot actually practice for the most part, because in order to practice with that existing credential, you have to work for a place that holds a certificate of authority to bill Medicaid, which is the only funding source that reimburses for QMHA services. So the subcommittee actually spent some time thinking about, would it be easier or harder to change that requirement? Is it possible to expand the settings that QMHAs could practice in? And ultimately, the answer we landed on was it's much more complex from a policy perspective to try to change some of those policies that regulate the settings where folks with a QMHA and other MACBO credentials can practice than creating a new credential. Although, Eric, if you want to weigh in and add anything here, please do.
No, that's completely accurate. It needs to be with MHRA and it needs to be a license so that people can get reimbursement outside of COA programs. And then also access to the individuals that you're trying to do prevention with. So most COA services are not prevention-oriented services.
Exactly right. Thanks so much, Eric. And so, to reduce regulatory complexity, the recommendation is proposing that this new credential would sit within an existing board at MHRA rather than creating a new board. We're in conversation. MHRA is sort of aligned with our recommendation that the Board of Psychology should oversee this credential. We're having conversations with them right now, so I don't want to say like two thumbs up, but at least thus far, there's been openness to this idea, and we're continuing to discuss it. And situating the credential there would mean that behavioral health professionals who have some of the highest training requirements would be overseeing the implementation and regulation of this new credential. Okay, so at this point, I will sort of welcome questions along the way. I appreciate you all just sort of letting me get through the high level summary of the recommendation itself. But I'm going to quickly address sort of why this recommendation was made. Okay, so I'm going to talk about some things that are probably not news to anyone on this call. And all of these sort of identified needs we think the new credential addresses have actually been pulled either from OHA reports to the legislature or other recent reports since 2023 to the Oregon legislature around the youth behavioral health workforce. So first, we know, like many places around the country, more than half of families in this state who seek behavioral health services for their kids report meaningful difficulty accessing care. It's really hard for families to access the services they need. We need to expand the workforce. That has been argued for in many, many legislative reports over the past few years. We know that there is a substantial need for both culturally responsive services as well as providers. Now, while a new credential is not going to guarantee that we would be doing a better job as a state in this area, I do want to just show a little data that comes from MACBO around how reducing barriers to entering the field is likely to increase the diversity of providers. So when we look at licensed master's level providers in our state, and I will say this is the level of granularity of the data I have access to. When we talk about workforce diversity, it reflects a whole variety of characteristics. This is focusing on race and ethnicity in a fairly non-granular way. This is the data I have access to, but just wanted to note that of course, workforce diversity reflects a lot more than just race and ethnicity. However, what you see in licensed providers is that 80%, 85% in Oregon identify as non-Hispanic and white. When we look at QMHAs, where there is a reduced barrier to entering the field and allows for bachelor's level folks to get credentialed, you see an improvement in terms of workforce diversity. You see a smaller number of those providers who identify as non-Hispanic and white. So we have some evidence to suggest that reducing barriers to entering the field is going to ultimately help to create a more diverse workforce. Now I'm going to hand it over to Jamie Vandergaan, who's here from Trillium Family Services, to talk a little bit about the employer perspective around the need that this new credential addresses, particularly around the need to build behavioral health workforce pathways that start at an early stage of professional development and that add kind of additional rungs into this continuum of behavioral health support we have. So Jamie, I'm going to let you drive these next couple of slides. Just tell me when you're ready for me to advance.
Yeah, thank you. Just as an employer, Trillium Family Services employs about 800 people, ranging from high school diploma to dual PhD MDs, sort of everyone in between. And when I look at the large majority of our workforce, of course, because of our intensive inpatient residential beds in Portland and Corvallis, we hire a lot of individuals kind of in that bachelor's level or QMHA range. And I love about the QMHA, and I would never want to see this change, that you can earn a QMHA with, I believe, correct me if I'm wrong, a high school diploma or GED and the supervised experience that you gain along the way. And I love that. And I would never want to change that. But just to draw a line on the point that that ranges from that level to you are just one credit shy of your master's degree, or it just has not been legally conferred by your university yet. That is the range of a QMHA, right? From the academic perspective. And so having another progression in the middle of that, a place in the middle to earn a license, to earn an additional credential, I see as being a major asset to a workforce like my own. I'm trying to evolve and elevate that intensive psychiatric residential care. That's our most vulnerable kids, our kids with most significant mental health concerns. And if I had a workforce that was coming in that middle level where they really have some evidence-based skills that they're armed with, much like a nurse who's coming in, okay, I can draw blood pressure, I don't know nurse skills off the top of my head. I can do heart rate, blood pressure, and draw blood. I have these, evidence-based skills in my backpack. I cannot wait until our behavioral health workforce is really showing up to the job with these kind of skills on their back, saying like, yay, I'm here to implement my toolkit. And I still absolutely want to hold space for individuals that have a QMHA by experience only, without the bachelor's degree, but having a broader range of these individuals, like I said, in this huge kind of chasm between a fully conferred master's degree and a QMHA by experience. It just feels like we are able to bridge that gap and create more of a pathway in the field. That isn't just, well, I guess you'll do your master's degree because that's the next rung kind of on that ladder. So yes, really leaning into this in the hopes of creating a more highly trained, skilled workforce, and also elevating and standardizing that training to prepare for this group of individuals that is not just so employer based. The training and skills you get right now very much depends kind of on your on the job training that you're receiving, and some people may do A+ job at that, and some organizations may not have as much robust training for staff in those positions. Let me see. Yeah, maybe. Do you think I covered everything here? What do you think?
You got it. Yes. And then so the next slide just around outpatient settings.
Yeah, I mean, Trillium is not a shift model team, but there are many of you here that are probably unfamiliar with the shift model and with Care Oregon's move there. That is also a model that really values team-based care and that QMHA position in there. And just having more highly trained providers to be able to practice at the top of their license, it kind of delineates more the roles that people are filling. We do, I think, in our field struggle sometimes to delineate when you're working on a case together, right? We'll have a team, we'll have the psychiatrist, the therapist, the master's level clinician, and the QMHA and peer, and always looking for those places where we can more clearly define the role that each person is playing in caring for that one youth and families team, and hoping that by adding this kind of rung on the ladder, we could do that. So I apologize. I'm supposed to be at the First Lady's Recruitment and Retention Subcommittee right now, and so I do have to bounce pretty quickly here. But
thanks for being here, Jamie, and I, we'll follow up if there are any questions that arise from the group that really should come to you. And thank you for making the time to be here despite having a conflict. Okay, so really briefly, the other identified needs, the credential addresses. Many workforce reports to the legislature have identified the need for more prevention-oriented services. How amazing would it be if we could identify kids who are struggling at an earlier point in time, deliver early interventions that we know can be sort of brief and lower intensity, and put kids on a better pathway moving forward than waiting until the problem has become really severe to help kids get connected to services. And that these services are really needed in places where families can easily access care, like primary care and schools. And this won't be a surprise. I'm not making it up. This comes from Mental Health America, a national mental health nonprofit. They currently rank us, Oregon as a state, as 49th out of all states on youth mental health. We need to do something new in the state. We need to think about how we address these needs in a new way. And this is one of the key ideas that's emerged from the 4151 conversations about how we can better serve kids and families in our state. Okay, so let me address some of the concerns I heard from all of you, as well as from 4151 members along the way. A question has been raised, like, who's going to pay for this, right? Who will pay for these new services being provided? As I mentioned earlier, credentialing is really a first step to create necessary billing pathways. I don't have an answer for you today, but the hope is that, the Oregon Health Plan and how services could be billed to the Oregon Health Plan will be worked out with OHA and with Care Oregon if this new license type actually gets enacted in law. The hope is that private insurance would also reimburse for some services eventually, but that also remains to be worked out. So the real answer here is we don't know for sure, but we'll continue to work on this if the license moves forward. So concerns have been raised around workforce preparation, right? Are we just reducing qualifications for practice? How is this impacting consumer protection? So my answer here is that, individuals with this new credential actually would be receiving more specialized educational preparation and more applied training than is typical for entry-level roles in behavioral health, not less. And we're really thinking about, just as Jamie said, kind of thinking about adding a new rung in this continuum of behavioral health support, where we value all of the rungs, but want to make that sort of ladder, if you will, into the field, have more rungs that, allow folks to continue to progress along their training pathways. And as I mentioned earlier, a license is actually really an essential consumer protection tool. It provides guardrails around practice that help to protect consumers. So scope creep has arisen. This specifically came up in 4151 discussions, so I'm just going to name it specifically. Folks raised concerns around scope creep for peer support specialists, and is the same thing not going to just happen here? What I will say is scope creep comes up as a concern really when you're talking about any kind of behavioral health role, no matter where it is along that ladder or continuum of support. As I'm going to sound like a broken record, this is why you need a credential, right? Or a license. It creates that guardrail around practice and enforcement mechanisms to ensure that practice stays within scope. So really good training and really good sort of licensing guardrails are the best things we can do to ensure or to try to prevent scope creep. Oregon right now, actually, the conversation that I think, that are happening, that are being convened by the First Lady, as well as others, are really thinking about how do we consider credentialing pathways for other critical behavioral health roles that are in that ladder of support, like peer support specialized, to provide clarity around scope and to professionalize those roles in the way they deserve. Okay. Concerns were raised or just questions maybe about overlap with existing roles like peer support specialists. So what I would say here is that many mental health roles share some areas of scope, right? Like everybody does case management and care coordination to some degree. Some of these are just practices that are fundamental to being a behavioral health provider. And in that way, this role does overlap in some ways with other roles. But, the part that's really unique is this focus on early identification, prevention, skills instruction, which is distinct from other roles. In the interest of time, I'm not going to dive into this figure in a lot of depth, but it is provided in the slides, and it really identifies sort of where the scope kind of overlaps with community health workers or peer support specialists, things like health education and care coordination, and places where it really is distinct in the space of low intensity, brief kind of prevention-oriented interventions. Okay, a question was raised, along in my conversations with all of you about, are we going to really increase access to care? So what we are not doing here with this recommendation is creating a bachelor's level therapist. That is not what this role entails. And it requires being supervised by a licensed provider. So are we going to really increase access to care? It's a really fair question. So my response to that is that, with a scope of practice that emphasizes prevention and early identification in community settings where families can easily access support, the idea is that if you can start to identify kids who are struggling at an earlier point in time and deliver what we know are effective evidence-based interventions that can prevent at least some of those kids from worsening in terms of their behavioral health, you'll prevent some of those kids ultimately from needing a more highly trained provider. Now, it's not going to happen immediately, right? But if we ultimately are able to train enough folks with this scope of practice, that's the whole public health idea, right? Is that fewer of those kids who interact with folks who have this kind of training will need a more highly trained provider, which frees those folks up to really focus on the kids who do, the kids who require more intensive interventions and always will. In the UK, where they've been using bachelor's level providers pretty intensively, in a very similar way to what we're proposing here for the past 10 or 15 years, what they see is about 1/3 of folks who actually come seeking care have their needs sufficiently met by a bachelor's level provider. They never need to get referred up to the next level of care. So we don't know, of course, what this would look like in Oregon, but it is some evidence to suggest that this workforce can help address the needs of at least some youth and families who may not require more intensive services as a result. Okay. A concern actually raised specifically in the family council, SOCAC family council conversation I had, and one that actually comes up a lot is, okay, this is a new role that's going to be focused on identifying kids who have behavioral health concerns at an early point in time. Given what are you going to do when you identify a bunch of kids who have pretty intensive needs, who need services right now, but we don't have enough master's level providers to refer them to? This is a really common question. What are we going to do given the shortage of licensed professionals? So a few things that I would say in response to that is that first, it's better to know than not know, right? It's not that because we suddenly know this kid is struggling, we didn't create that stress. They were struggling regardless of whether we knew about it or not. Knowing is always better, right? And when we talk, some of our school partners, one of my colleagues said to me, think about reading. Would we want to just pretend that we not know that a kid is struggling to read? Even if our school doesn't have the intensive literacy services we'd like, it's still better that we know, right? Than not know that that child is struggling. And when we think about settings where these folks will be practicing, like schools, even if there isn't a more highly trained clinician available immediately, it's helpful to all of the adults in that system to know this is a kid who's struggling, the teachers, the school counselors, everybody in that system who could help to provide some type of support while, that child waits to get connected to a more highly trained mental health professional. And finally, these BA level providers we're talking about who identify this need, there's a range of skills that they can deliver. Interventions they are capable of delivering to build skills while they wait for a more highly trained clinician to be available. So we think it's still better than the status quo of not knowing that these kids are there and are struggling. Okay, really importantly, a question that came up in family council as well. Is training sufficient? So the idea here is these folks would be required to have training in culturally responsive and inclusive practices, to qualify for this license type. Is training really sufficient, though, to increase culturally responsive practices? And remember, this was part of the mandate of 4151, is to focus on roles that could ensure a more diverse workforce as well as more culturally responsive practices. So, what we talked about in that discussion is that it's not just about training, but you really have to have a desire, right, to deliver these kinds of services. And training is never going to get someone who doesn't inherently value this, most likely, to suddenly value it. However, we know that there are lots of providers who do value this kind of service, who want to be culturally responsive, who want to deliver inclusive practices, but don't actually know how, right? That need that training to be able to do it well. And that's the piece that training can address, right? It's not going to address the folks who don't inherently approach their work with this as a core value, but there are many who do, who could benefit from this kind of training. And of course, our hope is that this proposal, this recommendation is going to help our state make progress, not only in the diversity of providers, but in cultural responsiveness. But it's not guaranteed, but it is the hope in creating this recommendation. Okay, and finally, a concern raised in conversations with all of you is, okay, if we're going to create a more diverse workforce for folks kind of coming into this sort of entry-level behavioral health roles, are we really doing them a service if we don't have enough culturally responsive folks who can supervise them using culturally responsive practices? It's a really important concern. And actually, it's another recommendation that will be coming out of 4151 that will come to all of you when that full report is created, I believe in December. I'm not sure when the presentation to all of you will come, is an additional recommendation that's really around increasing evidence-based supervision and culturally responsive supervision and access to training resources in that in the state for master's level providers for this and for so many other reasons. Okay, so where have we been in this conversation? Just to recap, the recommendation, legislative recommendation coming out of 4151 at this stage is a recommendation to create a new bachelor's level behavioral health credential that we hope will reduce barriers to entering the workforce, that will help to expand access to support for kids and families, will be really a role in our system that really brings this kind of public health focus into our behavioral health system in the state, where the scope is focused on identifying challenges early and providing access and delivering these evidence-based early interventions that we know have the potential to prevent problems from worsening over time. We hope this recommendation will help to increase the diversity of the workforce in the state and will ensure that providers have this early training in culturally responsive and inclusive practices. And ultimately, as Jamie highlighted, really create this new rung in the continuum of behavioral health support roles. Every rung in that ladder is important. Every rung is valuable. And it's really kind of adding a rung that exists between our current sort of entry-level roles and then being a master's level provider to really provide that sort of opportunity for advancement along a clear career pathway. So that's it for me and my slideshow. I'm going to stop sharing my screen and happy to spend the rest of the time we have answering your questions and addressing any lingering concerns. Thank you all for making the time.
Yeah, thank you. So we have some questions in the chat if folks want to queue up with your hands as well. Let me see here.
Yeah, Adam, do you wanna drive those questions, or should I just scroll?
Yeah, I can go for it. Yeah. So it looks like at 3:48 in the chat. Are there any recommendations for exactly how many hours of supervised clinical time needs to be completed for this credential?
So what we're currently discussing now, ultimately, if this legislation is enacted, the Board of Psychology, if they indeed are the overseeing board, would make the decision about that. But the recommendation is that within your degree program, so during the context of your bachelor's degree, you would need at least 700 hours of supervised applied practice. And then we also talked about, well, what about practice on the other side of the degree, like post-degree hours? And what's interesting is because this role always requires supervision, right? Like we often have a requirement that post-degree folks continue to get supervised hours, but these folks always have to be supervised. So I think there's some questions about would they need to continue getting additional supervision to qualify after the degree or not? That's ultimately a question the Board of Psychology would make a decision about because, as we talked about, these folks would always require supervision in their role. But 700 hours is during the degree program is currently what folks are discussing.
Follow up to that, could this credential be earned entirely online, including the supervised work that you're referring to?
That's an interesting question. We hadn't thought about it that way. I'm not aware of any currently fully online programs that would offer this kind of training. The existing programs in the state that do really are sort of in-person programs that require in-person service delivery as part of it. But there's not any necessarily reason that wouldn't be possible. That programs that deliver remote instruction to make it more accessible to remote areas of the state could create those opportunities. And there's nothing about the recommendation that would necessarily prohibit that.
Next up, Alicia, I'm looking, so I see you there. Okay. You put, can you elaborate on why the decision was made to place under MHRA instead of the Board of Licensed Social Workers? Do you feel like you got that answer, Alicia, or?
Oh, no, I just wanted to make sure that is like clear and out in the open, because that was one of the conversations that we did have in the subcommittee. That we really discussed why it should be placed under the MHRA rather than the other licensing board.
Yeah, thanks so much, Alicia. And actually, Ray Miller, who was oversees the board of the social work board, was part of these conversations. I think he'll be joining you in a couple weeks to talk about another recommendation coming out of 4151. It was the scope of practice here, was felt is really much more aligned with a folks who have a psychology background. A lot of the interventions, the prevention-oriented services really have grown up out of psychology, and the scope of practice folks felt was more aligned with with sort of oversight from the Board of Psychology than from social work. And I think there was pretty broad agreement about that. MHRA, who oversees the Board of Psychology, was also sort of in agreement about that and has been willing to sort of absorb this credential into their workload. Thank you, Alicia.
I think the last thing is there's a fair amount of discussion in the chat about psychology degrees likely not being eligible for this because of the lack of applied science nature, essentially, of the degree. And there's some suggestions there, some concerns that would be excluded and then overseen by the Board of Psychology, right? And then also some consideration or refinement of that recommendation to have an applied degree or have supervised experience after completing a relevant degree to qualify. So I think that sums up the chat.
Well, thank you. I appreciate that, Adam. So this is a really good question and one that's come up a lot in conversations as well. And I think the idea is as the bill language is getting worked on, the idea is that there needs to be a recertification pathway, just as folks are addressing. So for folks who, graduate with a psychology degree or with another, behavioral health type of bachelor's degree that didn't provide an opportunity for applied training, what's the pathway for folks with that kind of educational background to have access to this new, license type? And so there's language that would be going into the bill to specifically identify what a research or certification pathway would look like. And it's interesting because this, sort of license type inherently requires educational sort of super, clinical experience that's part of an educational program. And we also don't want to make it just exactly the same pathway as a QMHA, right? Where there's a workforce pathway to becoming a QMHA. The idea is we would think about what are ways that this kind of recertification could happen in the context of a brief sort of educational program where that clinical experience is coming as part of maybe a 1-year program you engage in to sort of get you that clinical experience as part of an educational, program, not necessarily a workforce pathway. But that all is still sort of up in the air and would ultimately get decided in rule by the Board of Psych. But everyone is in agreement that there needs to be a pathway into this for folks who have already gotten their bachelor's degree, maybe aren't ready to go get their master's, but would like to be able to get this kind of training and do this kind of work.
Thanks. Dan, you're first up in the queue.
Thanks. First of all, I want to say I think this is a really thoughtful proposal and can see a lot of benefits to proceeding in this way. So my concern here is not an expression of opposition, but do have a concern about, or a couple of related concerns about the scope of practice. One being that the terms support and brief intervention are pretty broad and vague, whereas the term like skills training and psychoeducation are much more specific, and it's pretty easy to pin down what those things actually are. And so I think that might need some work, and particularly if we look at there being a prohibition on unlicensed providers offering these services, it would be pretty difficult to imagine a world in which people without a license aren't able to provide support to each other. So again, just some things that need to be thought through in those respects. Thank you.
Yeah, that's really helpful feedback. And, as we've been working with MHRA to actually put this into statutory language, ultimately where things landed was that the scope of practice here would not actually be protected in the way that, like, the practice of psychology, the practice is protected. What would be protected here, and the title, you can't use the term psychologist if you're not a psychologist. So there'd be title protections around this license type, but because the scope of practice does over, like, a psychologist could deliver any part of this scope, right? There's nothing about this scope that would require that only these providers can do, prevention services, skills training and support, and so on. So you're exactly right. And as you think about the statutes that would govern this, there'd be a title protection, like you couldn't use the term, and who would want to really, because it's a mouthful, licensed behavioral health and wellness practitioner. You can't use that term, right, unless you qualify for this license type, you hold it. But many aspects of that scope are not protected because other behavioral health providers, could engage in those services as well. I'm not sure if that totally addresses your question, but I think it's also a really important one as you sort of move from the idea into the statutes to make sure that scope is really clearly articulated in a way that is specific.
Yeah, other behavioral health providers, but also people who aren't behavioral health providers at all.
Yeah.
Can do some of these activities.
Absolutely. Thanks, Dan. And I see Annette's hand next.
Hi, Kate. My question is really around who is this bill going to hurt and who is it going to harm? And I'm thinking about those folks who are in communities across Oregon working with their either CRM or their QMHA, and they're doing boots on the ground work. Is this bill going to help those people into a bachelor's level situation? So I'm thinking about those folks who are putting in the work. And so my question to you is, how does this help them? Is there a pathway forward for those folks?
Yeah, it's a great question, Annette, and thank you for asking. So, when we think about, as Jamie was highlighting, sort of the need for building more kind of rungs in the career advancement pathways for folks who enter the field as a peer, as a QMHA in these different roles, the hope is that, yes, this provides an opportunity for folks who haven't yet, completed their bachelor's degree or who completed a bachelor's degree but didn't have applied training as part of that, to have an opportunity for an educational experience that's accessible, but that's less expensive and time intensive than getting a master's degree, which right now is sort of the next opportunity available for folks with that, in the roles that you highlight. And so that recertification pathway is, I haven't been monitoring the chat, but it sounds like there was a lot of information in the chat about exactly the question you're asking. Like, what about folks who have a bachelor's degree already, but not who didn't get that applied training as part of it? Because the reality is most of these programs are quite new, right? This is a new thing that, Oregon has really been leading the way on is building more bachelor's programs that provide this kind of training. But the hope is that, and the bill would include language that specifies a recertification pathway as well, so that folks can access this credential, without going back to school and getting a whole new bachelor's degree, right? Of course, that's not going to help anybody. And so thinking really clearly about what the scope of those recertification programs would be and how many hours is required, for example, is part of what would have to be put down in statute as these, as the bill is moving forward. But that has absolutely been part of the conversations with MHRA and will be included. Thank you. Alicia.
So I wanted to just highlight one of the parts or one of the questions that was mentioned earlier in the chat regarding the training, if folks can access this online or this training online, including the practical piece of it. And we did actually have several conversations about the need to ensure that it is accessible in areas, particularly when the conversation was about rural or access for rural folks. And I think, Kate, please help me if I'm getting this wrong, but I know there was conversations around how there might be some necessity to actually dig a little bit deeper at a later time to look at some of those potential statutory or regulatory barriers that could help with opening this particular credential up. Could open it up even more for other folks too.
Yeah, thanks, Alicia. So yes, I mean, in terms of what is available in the state right now, I'm not aware that there are existing programs that could provide a fully remote experience, but the bill would not prohibit that, right? That, the idea is that the hope is that as capacity first, the hope is that once you create a clear career, and license and professional role for folks who have this kind of bachelor's level training, it creates more demand for this kind of training, that we'll see more programs in the state, more universities start to offer these kinds of programs because it offers their graduates, a clear professionally defined role that they can enter into, after they graduate from college. And so the hope is this will help to fuel growth in these types of programs, and that as these programs grow, it'll be increasingly possible to offer really high quality remote instruction. And I can speak this, this bill is not about any one training program, but the training program that I run at the University of Oregon, we have been thinking about from the beginning, how do we make these applied training experiences accessible for folks who are from rural parts of the state, who might not have the luxury of coming to the Portland Metro for a couple of years to do their applied clinical training, and sort of working to think about how do we create a really high quality remote experience that would allow folks to practice in a remote place while still doing some of their coursework remotely. So it would open up opportunities throughout the state. So nothing about the bill would preclude that. But the reality is that available today? I'm not aware of that yet. So thank you for highlighting that, Alicia. Ebony.
Hello, everyone. And I've been driving for much of this meeting, so forgive me if I've missed some things, and I'll go back and inform and educate myself should I need to. But I've kind of 3 points I just want to raise. Working in the realm of public health and behavioral health, I know there's kind of the concentric circle, and I do just think it's going to be super important to make sure that, as this moves forward, or, as there's kind of a recommendation, how are we being specific to naming and being intentional around the scope specific to the realm of behavioral health. And behavioral health does definitely include aspects of prevention, but I just think it's super important to be clear. Are we talking about public health? Are we talking about behavioral health? Or how do we, kind of name the intersection? I think, oh gosh, I don't know if it was Adam or someone else already brought forward kind of just wanting to, my mind to what is the scope of prevention specifically, just because prevention should look different and there should be some key strategies that are focused within the behavioral health realm. And so just really, naming kind of what the scope of prevention looks like, I think is going to be important. And then I just was wondering, what will the evaluation of this look like should this move forward?
Okay, great questions, Ebony. Thank you. So first, let me just emphasize that I think you hit the nail on the head of sort of where folks in 4151 envisioned this kind of license type sitting, which is really that intersection between behavioral health and public health, right? And how do we bring a more prevention-oriented lens into the behavioral health workforce in a really intentional way? In terms of what the scope of behavioral health prevention looks like, also a great question. The way that we've discussed this as part of the work group has really been thinking about, when we look at the continuum of care, the idea is that we have a new professional role that's really where their role is designed to both be working in settings where it's easy to engage in early identification, where you might identify a kid, for example, using screening in a school or in a pediatrician's office who hasn't come to adult attention yet, that is struggling with behavioral health challenges, but no one's really aware of it yet, or it hasn't started to really interfere with their life. And then delivering what we've conceptualized as kind of brief evidence-based interventions, not psychotherapy, but sort of skill building types of, interventions that are evidence-based that we know can help prevent, that child from progressing to a point where, they develop a more concerning or more impairing behavioral health concern. And so, spelling out exactly what those interventions look like, I think it will be part of the work that comes from creating this new license type and starting to train this new workforce. Really, where is the intersection or sort of the, how do those interventions diverge from what you might see like a QMHA delivering? And Eric can sort of speak to this, but as part of the conversations we had in 4151, right now, at least in the state, QMHAs tend to work often in residential settings and, in settings where they're working with kids who have some of the most intensive behavioral health needs and less at this kind of early part of the continuum of care where these kind of more brief early interventions might be effective. And then in terms of evaluation, it's a great question. I think what I can say for our training program is that we're doing a ton of intensive program evaluation following folks who get this kind of training, evaluating the skills that they're building as part of the program, the workforce pathways that they take, the job retention, ultimately like how much money these folks will make. We have no idea what the salary would be, for this kind of new role, what kinds of services could be reimbursed. And so there are a lot of questions, and I think, evaluating what the impact is on growth in the workforce as well as sort of rates of pay for people who get this kind of training is going to be really, really critical. And, our hope would be to partner with OHA and others to really figure out how best to evaluate this in exactly the way you described. So thank you. Eric.
Adam, are you cutting me off?
Nope. We're going to get through the queue of folks with their hands raised now, and then we'll see go from there. So you're up.
Okay. So my internet is unstable. So I don't know if I'll cut out. But one thing I would like to say is that this is a specialized license and degree focused on youth intervention. So general degrees in psychology, they might have one class on like development, go over Erikson and Piaget, and that's about it. So I don't know that most bachelor's degrees in psychology would meet the intensity of the level of training that goes into prevention and brief intervention for youth, that's happening at U of O. So that, that's what the focus is here. And I don't think this is going to displace any workers because currently I don't think anybody's doing it. There is no behavioral health sort of screening and intervention services that are happening in primary care. And there is some in schools that are contracted with some COA. For the most part, it's not happening. That's why Mental Health America ranks us 49th. And I believe, and I don't know if there's anybody from OHA that can speak to this, but I believe that, what in prior years, I just vaguely recall that their target for the CCOs was for 10% of youth to have an expert screening. 10%. And that was like the target that they were like hoping to get to was 10%. That's all.
Thanks so much, Eric. And you're totally right. Like an average psychology degree would not have the coursework that would be required to meet meet the training requirements for this new credential. And so you'd have to do some kind of recertification program that not only includes applied training, but also coursework that's specialized in child development and in prevention skills and so on that, it couldn't just be a workforce pathway to getting this credential for exactly that reason. Andrew.
All right, my turn. Okay, so I really appreciate this. I think it's important. I think it's a conversation we have to have and we'll continue to have. I think what we're talking about with recertification is a pretty big deal. And I feel like we need to pin it down a little more and not leave it to chance. Like maybe in the rulemaking process, it'll bear itself out because, for example, there are other kind of credentials. You look at the CADC credentials, for example, they can specify the types of education you need to get and the types of supervision that you need to get that doesn't tie you to a specific academic program. And the reason why I think that's important is that if let's say you do have a bachelor's degree, maybe you have lots of coursework that is relevant, but you don't have applied training. Do you have to go back through a whole academic program? And if so, you're going to create a barrier for people because most of the time that kind of applied training is not paid. And so I have a bachelor's degree, but I have to go back and provide 700 hours of supervised training and pay for more time in an academic setting. Lots of people won't be able to do that. So I don't mean to say I have all the answers, but I think those are gonna be some barriers, and I don't think we should leave the recertification thing to chance.
Yeah, I appreciate those comments, Andrew, and it's an interesting balance to strike between, wanting to ensure folks have had the, relevant training experiences and not creating more barriers, right, to getting into the workforce. So, it's interesting. I can speak from my experience in our training program. Actually, more than half of the folks who provide applied training sites for our students pay them, typically about $25 an hour. So some of the norms around getting paid for training hours, have changed since I was trained. No one paid me for any of the training experiences I had when I was learning how to be, a psychologist. But the norms have shifted. Actually, a lot of folks who provide these internships are providing payment for students. Now, of course, that's not always going to be the case, but that's really not what your question was about. It was really, trying to strike that balance between ensuring folks have had the relevant training experiences, but not creating additional barriers. And I will say that's a place that 4151, we did not spend a lot of time talking about what the right recertification pathway would be. And it's a place where I think, as we sort of, move forward into bill language, I think folks would welcome recommendations, thoughts, conversation around like what's exactly as you're saying, how do we get that pathway right, to really strike that right balance between ensuring, the right training experiences, but not creating more barriers. So I appreciate the comment and would welcome further conversation or ideas that people have about it. Marisa.
So I know like it's not flushed out yet, but it sounds like the area that you're talking about is more skills training and not children who are at an acute level. It's more identifying something like, for example, on the playground, kid doesn't get what they want, immediately goes out and stalks somebody because that's their reaction. So you would try to give them social skills, anger management, or maybe something else. I mean, just on the short level.
Yes.
Is that part of the range that you're talking about?
Absolutely. Right. So thinking about schools and the idea, some of the, training in early identification would also, focus really heavily on using screening tools, right? Which, it's interesting. Oregon doesn't currently require, but increasing number of states, Colorado, Illinois just passed a bill that actually requires schools to do this. That, we know screening is actually a more equitable way to identify kids who could use support in schools than just focusing on, kids who may have observable behaviors that are interfering with class or sort of getting in the way of their functioning at school. And then, helping to identify kids, not just the kinds of kids with externalizing problems, but kids who are suffering more silently with depression, with anxiety, with suicidal thoughts that haven't been shared with others. And then they would be the workforce to do exactly what you're describing, not just figure out who those kids are, but be there to run a skills group, right? Teach some basic, interpersonal communication skills, anger management skills, conflict resolution skills to help kids who are starting to struggle, but maybe who haven't yet sort of risen to the level that they're, that they need, to be engaged in therapy. That's really the scope for this role. So you've hit the nail on the head with your example.
All right. Thank you.
Yeah, thank you. Adam.
Yeah, I promise this wasn't like me squeezing in the last question. I did actually have a question and I dropped out of line when I went off mute previously. I think my main concern, I appreciate the work and I don't want to get too into the weeds about kind of how outcomes happen because y'all put a lot of time and energy into that. So I want to express my appreciation. I think my concern is around equity. And when I'm looking at creating this to be used in what I heard was like schools and PCPs, right? Or like primary care physicians, like community-based comprehensive behavioral health centers, those sorts of things. And I'm looking at Eastern Oregon, right? And we've got our population like of folks who have bachelor's degree or above, right, in Morrow County is under 10%. And the percentage of Latino folks living in Morrow County is 44%. Malheur County, the percentage of Latino folks is 35%, and the bachelor's degree or higher is 15.5%. And so I think for me, that's a concern when we talk about adding diversity to the workforce, but requiring a 4-year degree in order to access that. And so I think I just wanted to voice that concern, especially for rural and frontier populations, that they may be excluded out of access to this sort of support based on the current recommendations. And I think, I know this is a tight turnaround. Cody, you're probably really gonna be concerned when I say this, but I do think there's there's value to a full gear tool analysis to look through this. So I think for me that would be a request. Cody, is that a reasonable time frame?
Well, I get married this weekend, Adam, so I'll check with my fiance on if I can postpone it. But
no, I knew that was coming. I didn't remember exactly when.
So I'm out for the next several days. I also think equity analysis is very good. I think maybe the 3-question one would be a little feasible for folks that are able to do it, but I'm open to other thoughts.
Okay.
Well, congrats.
The other thing is
clarifying question to Adam to your question.
Yeah.
or your comment. Are you saying that, I don't know if I understood what you said.
Yeah.
Are you saying that certain people in certain areas would not have access to this education program to be eligible for this credential?
They don't have the workforce to then have staff to perform the service. And also, generally, the folks living in those communities are less likely to have a degree of any kind. And the specificity of the a degree and the access to it, if you live in, you know, I'll just throw out like Spray, Oregon, in Wheeler County, you're 4 hours from a physical university. So do
And
folks
so,
living, yeah, do folks living
yeah,
in
and
those
so is so is the question that this ought not be a credential because it's not equally accessible to everyone across the state, or that there should be some accommodation for lesser amount of education? I'm not sure what it is that you're proposing in bringing that up.
Well, I'm proposing we do the evaluation of the impacts of creating a credential like this using the tool, racial equity.
I see.
Because I don't know the answer, but I think I have some concern that there's unintended impact.
Well, I appreciate those concerns, Adam. And I guess what I would say is that to currently qualify for a license in the state, for a licensed behavioral health role, you need at least a master's degree. That's all of the licenses that currently exist in the state are at the master's level or above. Am I right about that, Eric? I see you coming off mute.
Yes, that's right. So, I mean, again, we're talking about service that isn't really happening. So this license is going to fill a void where hardly anybody is providing the service. So there are some graduate level, I think, that are providing some level of screening and brief intervention for youth, probably in Kaiser, maybe in a few other systems. It's just not happening with any kind of regularity around the entirety of the state. So, so as Kate is saying, currently it takes a master's degree and a license because that's how you would get reimbursed is by having a master's degree and a license because there's no other reimbursement that's approved for anybody else in primary care to do this service. By opening the doors up for individuals with a specialty uh, bachelor's degree, at least you're opening it up somewhat under the current system, which is just a with a master's degree.
Yeah, and that's the hope. I mean, I think, Adam, the concerns you raise are really valid, and I'm not sure what the tool is, but or how quickly Cody can deploy it, given that congratulations, Cody, on your impending nuptials. But the hope is that, we're actually reducing barriers to entering the field, not creating new ones, right? Because what exists currently to be a licensed behavioral health provider in the state is a master's degree or more. And so, the hope is that while this isn't completely getting rid of any training requirements, it does require a certain type of bachelor's training. It's a lower amount of training than has been historically required in the state to create that entry level licensed position. So the hope is we're moving in the right direction as it relates to equity. And, this is something specific to a program that I'm involved in, not all programs, but, we offer a full ride scholarship for all 4 years for Oregon residents who engage in this program. We are lucky because of philanthropy that helps us support the program to be able to do that. Now, not all programs will be able to offer that, but there's a lot of ways to think about making sure folks who are interested in getting this kind of training can do it, even if they don't have the financial resources to do so. Scholarships being one key mechanism. And then Robin.
So sorry. I'm sorry, Kate, but we really are way past time, and Anna is pushing on me. in the chat publicly now. It started privately in text and got public. As we're significantly over time, we're going to push the committee reports until 2 weeks from now. But I know that we do need to do a quick report. So I think we're going to have to cut it there. Sorry, gang.
You know, I haven't spoken at all on this matter at all, but I won't take that personally, Adam.
It is not personal, Rob. I promise you. Like, I really do. I'm just trying to.
And I will say we have more time for this on September 16th. So we'll set a specific amount of time. If you want to send your questions to Kate in advance, please send them to me. We cannot have email discussion that's bouncing around about this topic, but you can send your question that you want Kate or anyone else from the 4151 committee to respond to. We'll send those to her in advance. We'll go through them, have a quick discussion, and then we will vote on whether to adopt this recommendation or not. We may need to push that back now with the GARE analysis that it can't happen on September 16th. And so I'll check with Cody and I will follow up with council, appointed council members on timeline on that. And Kate, I know you've done a lot of organizing, so I'll be in touch with you as well about timing. But if you didn't get to ask your question today, or you have another question that comes up over the next week, please email it directly to me. I will get it in front of Kate. We will address those questions in the at the September 16th meeting or whenever we do vote on this. This is a new procedure that we've decided to hear a report, give people some time to process it, and then make a vote on it in a couple of weeks. So bear with us as we navigate this new strategy. Thanks for being our guinea pig, Kate.
Oh, my pleasure. Well, thank you all for giving me so much of your time and space today. I truly appreciate it. I guess I'll see you all either in a couple weeks or sometime after that, depending on where the timeline ends up falling. Thanks for your time. Take care.
Thank you, Kate. Thank you for those who participated on that committee. Thank you all. We're going to move into public comment. So we have some time available for public comment, either on 4151 or items discussed earlier. Public comment is now open. Don't see any hands up. And if you do not feel comfortable coming to the microphone, you can text Alicia Overstreet, Joylene, or myself. So that option is available as well. Not seeing any hands, anything in the chat, no. Seeing no hands, going once, going twice. I think we can move on.
Thanks, Annette. And for those of you who are curious and did not attend our public meeting law training a couple months ago, we are required by law to create space for public comment at our meetings. That was not a tool used to shut down conversation. It is a legal requirement of our public body.
All right, so now we're going to move into our committee reports. So those committee leads, please step up if you have a report out.
And then we skipped this for to create space, right? So we have to push this to September 16th.
Okay. Okay, thank you. I didn't see that, so I'll turn it over to Adam.
Was there anything? So we do need to just touch real quickly about the meeting tomorrow at 8:30, the legislative meeting. Do you want to do that, Anna, or should Robin?
Looks like Robin is off camera. I'll go ahead and take it. Tomorrow at 8:30 to 9:30 on Zoom, the Legislative Committee will be meeting to review and finalize the 2025 System of Care Advisory Council Legislative Report. It is due to be turned into the legislature on September 15th. So that will be a report sent on behalf of the full council, but we'll not have time to come back here for final review and approval before we send it on our way. If you do not want the report to go without your review and approval, please come tomorrow to the 8:30 a.m. meeting of the SOCAC Legislative Committee. Robin, is there anything else you would add?
Nope, not a bit.
And that draft report is on the legislative committee invitation. I think it's already posted on our website for review. It went out last week to committee members and folks who come to that committee regularly but are not voting members.
I'm going to come to that meeting tomorrow, and Robin's going to ignore me when I raise my hand. Sorry, Frank.
All day long, Adam, all day long.
I do apologize for folks having to cut that off. It was a robust discussion, and I'm sorry that we didn't have more time. Some announcements from our crew. So I'll let Anna take this as well.
Thank you. So OHA is seeking public comment on the rural health transformation plan. I thought that might be just the kind of thing some of you all have opinions about, and so I just wanted to call it out. It's not something we have time to sort of generate as a council document, but inviting each of you all with your independent wisdoms and council member expertises to submit. Oh, it's too long. All right, I'm going to have to do this in 2 parts. To submit comment, and I'll put the information about it in the chat. So here is part 1. Come on, let me paste it. Oregon. Okay, I'm gonna have to chunk this up into pieces. Here is part 1. Bear with me. Part 2. Hopefully this all fits in part 3. Yes. Okay. So the Rural Health Transformation Program is a one-time 5-year program established via HR 1, the big bill that everyone is talking about that has major impacts on the federal budget, specifically to Medicaid and other related services. So OHA is gathering public comment for how they want to see that plan play out. There are still some details that we are waiting to hear from the federal government on, but public comment is available through this link at the bottom through September 5th. So if that's of interest to you, please go make your voice heard and reflect concerns and considerations that you represent here on the council or as your own individual self. Don't represent yourself as a SOCAC member, right? We're not doing this as a team. We are doing this as individuals who have expertises that matter. Questions or comments quickly on that? Okay. Membership renewals. We have a number of people whose terms are expiring at the end of 2025. If you are eligible for renewal, you have heard from Adam Peterson. If you have not, it's probably because you missed the email. So he's reached out, and then if somebody said, yeah, I want to reapply, I followed up with an email that told you how to do that. I learned that you have to reapply as a employee of the state, because as a council or commission member, you are seen as an employee of the state. So if I sent you the external application link, let me know. I will send you the internal one. I think I caught everybody. I did that too. And we will be doing an interview process this time around. We're instituting some best practices that we learned about in Washington, D.C. around building a council and commission that really works together for systems change. So we tried it out on Dr. Ritu and reflected on that process. He is here today as a potential new member. And we will be posting new positions that are coming open for folks who are expiring and not returning. I think we have a pediatrician seat that will be coming open, and a child psychiatrist seat that will be coming open. Robin's seat will be coming open. So if you all know folks.
Psychologist. I believe.
Sorry, psychologist.
Yep.
We have the psychiatrist. We don't have psychologists. Sorry. We will be having 4 seats for people with lived experience coming open on legally coming open on January 1st. We are thinking about responding to a question in the chat. we are figuring out onboarding and trying to be thoughtful about how we bring folks on in a way that does not cause trauma, in reflecting on some of our past experiences with not providing appropriate levels of support and onboarding for people with lived experience. So stay tuned on that. But no, there are no family or lived experience seats that folks have declined to renew at this time. If that changes, it will be announced. All members, you have to submit a self-attestation form. It will go into your Workday profile. It says whether you choose to take compensation from the council for the work you do here and whether you are financially eligible to accept that compensation. You have to fill it out whether you accept compensation or not. We need it from everyone. So Corinna is sending that out. We are hoping that we can get them all back by September 30th. It is an annual process. Believe me, we don't love it any more than you do, but we do have to have you submit that form on an annual basis. So please find that form and send it back in. And we should have gotten everybody covered for the July strategic planning retreat. If you are expecting a reimbursement and you have not yet filled out different annoying paperwork, please let Corinna and me know, and we will work to get you into whatever the system is that you need to. There's 2 different processes depending on what you want. It's a whole mess. We do not guarantee timely reimbursement, but we will work with you to make sure you get your money back, hopefully before the end of 2025. Questions or comments on that before I move to the next slide? Our meeting schedule has changed. Don't forget, you should already have the 3 to 5 p.m. meeting on your calendar for September 15th. We will be discussing and deciding on the House Bill 4151 recommendation. We will now be hearing reports from our committees as well. And we are going to do a little bit of strategic planning prep work for the October meeting. In October, we have actually reverted in some ways back to our former meeting schedule. We're canceling the 2-hour October 7th meeting and doing a 4-hour in-person meeting on October 21st to dig back into the strategic plan. You will get more information about that. Please feel free to reach out. It will be at Portland State Office Building where we have done in-person meetings in the past. And that is all I have. And yes, Jesus confirming it is 2 3-year terms for people, not 4 years. And with that, we actually ended with a little bit of extra time. So sorry to rush you through. I was panicking a little too early, 7 minutes too early. Anything, co-chairs?
Well, I guess I would love to hear what Robin had to say, and then Alicia had her hand up too. But I don't know if it was a question for Kate because I think we've lost Kate. So was it a question for Kate, Robin?
You'll just have to wait and see.
Oh, the suspense. Okay. All right. Then I don't have anything else. Anybody else got anything?
I don't have anything else.
Okay. All right, then. Good to see you all. I'm going to text a couple of you and find out what your favorite variety of potato is because I didn't hear from everybody. So hope you all have a good rest of your day. We'll catch up to you soon.
Thanks, everybody. Appreciate it.
Thank you.